Welcome everyone. I'm honoured and privileged to showcase the design, results and impact of a cardiometabolic diabetes service which is piloted in Kent and Medway CCG. There's going to be lots of practical and useful information presented here today, which might actually give you some ideas for your diabetes service and help to make an impact with your patients. So you may want to get a pen and paper handy to take down some notes. Before we begin, I'd like to acknowledge the key stakeholders and organisations involved in this project. The service was kindly sponsored by the Polycar Diabetes Charitable Trust in East Kent and hosted by Medway Practice Alliance GP Federation, with the diabetes reviews being conducted by the Professional Pharmacy Services Group with assistance from Cardiometabology. As a full disclosure, I'm one of the non-executive directors of Medway Practice Alliance GP Federation, and I hold directorships with Cardiometabology and the Professional Pharmacy Services Group. First of all, why develop a service like this? There has to be a need. This image will signify something different for everybody, but we can all agree there is a struggle, whether it's for healthcare professionals or for patients. Personally, my primary motivation for becoming a healthcare professional was to alleviate this struggle for patients and try to ensure patients were empowered sufficiently to help themselves in times of stress and difficulty, exactly like the situations we're now facing with COVID-19. During my primary care clinics in 2016, I saw this struggle in my patients, desperately looking for the answer or just a helping hand to help walk them through some area of difficulty in their life. It's precisely this situation and my motivation to do the best for my patients, and I'm sure we all do, which prompted me to redesign the primary care pathway for diabetes. Of course, during pathway redesign, we need to consider a number of factors, and we have to meet a number of outcomes to show or prove some degree of success. This service was developed to help address a number of key challenges we have locally in Kent and Medway. Of course, these challenges may also be reflected in your area and nationally. And I love a good challenge as it drives forward innovation, progress, and better care for all of our patients. In Medway CCG area, compared with the general population, 88.6% of patients with diabetes are more likely to have a heart attack. And did you know 85.7% of patients with diabetes are more likely to have a stroke? And this is key, as the national value is actually 58.5%. And this is a stark difference between the national figure and figures for Medway in patients with diabetes. And simply put, it's just shocking. So a solution is urgently required to tackle this. And we believe that we have some way to go in towards that. If we look at the challenge of the workforce, 38% of full-time equivalent GPs in Medway are over the age of 60 and close to retirement. And we can see from this is a big problem. And we need a pathway which modifies clinical management to reduce the risk of these long-term macrovascular complications and, of course, addresses this critical workforce issue within the primary care NHS. For our service, our timeline begins with an attempt at another pathway redesign with the NHS England pilot for general practice pharmacists, which began in 2016. As part of this pilot, a number of pharmacists were tasked at their respective surgeries to conduct annual diabetes clinics due to the shortages of nurses in those roles. We analysed the data for the performance of those pharmacists from the pilot, and what we noticed was there was a vast increase in the number of patients meeting all three treatment targets of HbA1c, blood pressure and cholesterol as outlined by the National Diabetes Audit. We dove deeper into what was happening in those practices and investigated how to replicate that approach, and after considerable research and design, we came up with another pathway of diabetes care, specifically to target patients who require the intervention of HbA1c, blood pressure, cholesterol, and other cardiovascular risk management strategies. I wanted this model to fit into the new world of primary care networks, where you have a number of additional roles which are reimbursed by NHS England, which could actually be up to 6 clinical pharmacists. And one of these could be used to cover a whole primary care network which would relieve workload and demonstrate clinical outcomes. By March 2019, we had obtained funding for the pilot through the Polycar Diabetes Charitable Trust and had started recruitment of practices who were below the NHS England average of 41.7%. The CCG average at that time was 43.5%, and the time period we're talking about is 2018-2019. And these were for attaining the 3 treatment targets of HbA1c, blood pressure, and cholesterol in patients with type 2 diabetes. We approached 19 surgeries and 5 agreed to participate. After surgery setup was complete, we started to see patients in late April 2019. Throughout the service, an efficient appointment reallocation system was in place, with unused appointments being reallocated to other patients and surgeries if required. This allowed us to complete all of our patient reviews by December 2019, 3 months before the QoF year ended. We're now in phase 2 of a completely remote model of care for COVID-19, of which we'll give some details later. Our 5 surgeries which participated had been below average for achieving the 3 treatment targets for patients with type 2 diabetes for a number of years, as can be seen here. In our service design, we assess the needs of patients with diabetes locally, regionally, and nationally, particularly taking into account the aims and aspirations of the NHS long-term plan, which were to increase the achievement of the recommended diabetes targets, to drive down variation of care between CCGs and general practices, so then we could minimise the risk of future complications, provide additional support for diabetes service delivery, detect more cases of atrial fibrillation, and importantly, to facilitate the aim of helping the NHS prevent up to 150,000 heart attacks, strokes and dementia cases over the next 10 years. In the service design stage, after ascertaining the need for the service, which was very clear from the challenges we previously just discussed, and of course taking into account the national priorities listed in the long-term plan. We then needed to look at the current landscape of services which were offered in primary care, secondary care, community nursing, and community pharmacies. We engaged with key stakeholders to ensure this pilot was able to integrate with these services seamlessly and facilitated a symbiotic relationship with these other services. And this was key to ensuring our pilot service was more effective. This would also ensure future sustainability and acceptability. We knew what we wanted to achieve, and we set a number of goals and key performance metrics to measure outcomes, viability, and sustainability of the service. We needed to ensure that cardiometabolic care was key and used the 3 treatment targets as an indicator of provision of holistic care. It needed to be cost effective and sustainable, accepted by patients and other allied healthcare professionals, and also importantly, to go some way to solving the workforce shortage in this area by utilising pharmacists as part of a multidisciplinary team with other allied healthcare professionals such as nurses at the practice level to provide a symbiotic approach to diabetes care. How did we do it? The model consisted of 4 key stages: the pre-work stage, initial consultation, follow-up consultation number 1, approximately 1 month later, and then a second follow-up 2 months after follow-up consultation 1. This ensured the patient was followed up at least 3 months after the initial consultation and any interventions which had been conducted. Our pre-work stage consisted of multiple searches of the diabetes registers, which identified all patients who required an intervention of either HbA1c of over 58 millimoles per mole, blood pressure of over 140/80, or total cholesterol greater than 5 millimoles per litre. Once we had our initial patient list, this was reviewed to remove any patients who were pregnant, had passed away, or who were already under the care of the community specialist diabetes team, or secondary care teams to avoid duplication of work and to ensure the service had a seamless approach. The final list was agreed with the practice lead and then passed to them to start the process of measuring the 8 care processes, so we had the latest information and metrics. And this ensured that we could provide a holistic review of our patients. The final part of the pre-review process was then conducted for each eligible patient, and an individualised plan created to take into account glycemic control, blood pressure, cholesterol, and CKD, just to name a few. An action plan with at least 2 choices was documented, just in case the patient refused a certain option or it wasn't suitable for them. Here we have our GP surgery, conveniently located next to the community pharmacy. We're just waiting for our patient to arrive for their appointment with the practice pharmacist. Here he comes now. Let's have a look at what's happening. Inside the GP practice, we've got our pharmacist and patient here for their initial consultation. We allocated 20 to 30 minutes for this, and it covered diet, lifestyle, and physical activity, and explored any patient issues which required discussion. We asked every patient about structured education. If this was required, they were referred to the appropriate program. If we noticed no recent retinal screen within the appropriate time frame, then these patients were then referred as required. We also conducted a full physical cardiovascular examination due to the patients with diabetes being at high risk of macrovascular complications. Remember, one of our main aims is to target these macrovascular complications. If a blood pressure intervention was required, then this was remeasured. We checked each patient's pulse manually, and if it was normal, then we assessed blood pressure using an automatic device, or manual device if the patient had an arrhythmia or history of arrhythmias. The interventions were then discussed with the patient, and then we created a final action plan. We then agreed to a follow-up consultation 1 month later. But when we designed the service, we actually wanted to make sure it integrated with other services to have a joint up, stronger approach for the patient. And as you can see here, there's a little community pharmacy outside the surgery through that window. And that's because if an intervention was made for glycemic control or blood pressure, the patient was advised to utilise the community pharmacy for the new medicine service. And a message was generated on the prescription to notify the community pharmacist of a new medication and to encourage the pharmacist to ask if the patient would be happy to participate. So let's pop into that pharmacy now with the patient. Here we go, our patient's on his way to the pharmacy. Now we're inside. The patient would then attend the pharmacy with the prescription, and the community pharmacist would gain consent, provide information about the new medicines, and of course re-emphasise any consultation advice we had actually given during the consultation. They would then arrange a follow-up call or consultation at the pharmacy 7 to 14 days later to see if the patient had any issues, and then refer back to the practice pharmacist appropriately. If there's no issues found, then a further follow-up was conducted at day 28, again referring back to the practice pharmacist if required, which nicely leads us into our follow-up consultation back at the practice. So now let's pop back to the practice with the patient for our first follow-up consultation with the practice pharmacist. During this follow-up consultation, we then discussed any issues identified by the community pharmacist or the patient with any of the medications. If they had a blood pressure intervention, then this was remeasured again, and if any further medication was required, then this was prescribed appropriately. In terms of glycemic control, most patients were happy to complete a glucose diary when required. So this was reviewed with the patients during this follow-up consultation. And if we needed to make any further adjustments to medications, then these were either added or discontinued at this stage. Again, we could refer to the community pharmacy new medicine service as we did previously. After this, another follow-up was arranged, and the patient was seen again 2 months later for the final follow-up with their results. Just a quick note about injectables. Initially, we decided not to do this as our community diabetes nursing team were already tasked with this, and we didn't want to duplicate any services and therefore start wasting resources. However, very quickly it was realised the wait times were too long to access the service, so we decided to initiate injectables to reduce or stop clinical inertia. To cope with this protocol change, we used any unbooked appointments and then reallocated it to patients who required the insulin initiation and then titrated appropriately. For the final follow-up, patients were then reviewed with test results, and if any further interventions were conducted, then a follow-up was arranged with the patient's GP. I'm pleased to say this model bore fruit beyond our expectations. We saw 507 patients over 8 months, on average twice, and conducted 1,003 consultations, with an average consultation time of 25 minutes, lasting up to 40 minutes for the most complex of cases. Thankfully, patients accepted 80% of our recommended drug interventions, and I feel this was due to clear explanations given around macrovascular risk for that patient. We avoided 72 referrals to the community diabetes team through initiation and titration of injectables through the service, which saved approximately 6,600 in consultation and referral costs. Due to the manual palpation of pulses and subsequent ECGs, we detected 5 cases of atrial fibrillation, which were then subsequently anticoagulated, which comes with its own benefits. And detection of 2 cases of heart failure with reduced ejection fraction through careful questioning, medical history, and cardiovascular examination. Patients were then referred for an echo, and then we identified 2 cases of heart failure with reduced ejection fraction. This has significant implications for the upcoming direct enhanced service for identification of cardiovascular disease in primary care networks. Therefore, this approach to diabetes can contribute towards this service also. We saved nearly £11,000 compared with if the reviews were delivered by the existing approach at the respective practices. 68% of patients rated the consultations with the pharmacist as outstanding, with 24% rating as excellent, with the remainder rating as very good or good. And importantly, well accepted by other healthcare professionals who interacted with the service at practice level. This quote is from one of the GPs who helped as part of the service, and I think this speaks for itself, showing we integrated with the existing practice structure with minor changes to improve efficiency and deliver the required outcomes. Remind ourselves of the previous rates of National Diabetes Audit achievement from the 5 surgeries. As we can see, the surgeries were all below the 3 treatment targets for patients with type 2 diabetes. Our primary goal was met, with all practices now exceeding the NDA treatment targets locally and nationally by December 2019, which was a great result in addition to all of our other outcomes. We also wanted this service to have an impact on cardiovascular mortality. This wasn't a controlled study, however, we did measure the impact of our interventions on patients to ensure our prescribing was effective and value for money. Here we have the interventional targets for patients with diabetes in terms of HbA1c, lipid control, and blood pressure reduction. In the service, we reduced 83 patients' HbA1c by 0.9% or more, total cholesterol by 1 millimole or more in 70 patients, and reduced blood pressure by 10/5 systolic and diastolic, respectively, in 83 patients. If we did this for 5 years, we would have the potential to prevent a number of cardiovascular events. And this actually emphasizes why multifactorial management is absolutely key. So what's next? We've been kindly funded again by the Pollock Diabetes Charitable Trust to start wave 2 of the service, which has been redesigned to deliver the service remotely due to COVID-19. We'll use lots of innovative technologies and approaches to help facilitate patient management, as we all know that this is actually imperative, especially at this time, given the current evidence of increased risks of mortality from COVID-19 in our patients with uncontrolled diabetes. This presentation has provided some useful insight into our project and service, and I'm happy for people to contact me for any help or assistance or any further information if they wish to replicate this approach elsewhere. Thank you for your time.